Hi, everyone, and welcome to IPHA's third Thursday Lunch and Learn web series, organized by the IPHA Education Committee. I am Lina Reinders, and I am the Executive Director of Iowa Public Health Association, and I welcome you here today, and I welcome you to all of our events, and welcome you to join us as an association. We dedicate this time every month to sharing our successes and even some of the detours it may have taken to get us there. The pivoting we're doing now is a good example of all that. The point is always to learn, to connect, and to strengthen the voice for public health in Iowa. We're glad you're here, and I hope you'll be back with a friend next month. Today we're talking with Dr. Michele Devlin, who is a professor of public health and education, and the director of the Iowa Center on Health Disparities at the University of Northern Iowa. We will be talking about racial disparities in Iowa and what it means in the day of COVID-19 and as we recover and as we move forward from this pandemic. A few housekeeping items. I have placed everybody on mute, I believe. At the end of my conversation with Michele, we will unmute people and you can ask questions, or you can always type them in the chat box. Please go ahead and turn your video off if it's not already done, so that everybody can enjoy the presentation, the discussion from Dr. Devlin. If you have any questions, again, feel free to use the chat function and we'll get those incorporated. Without further ado, let me go ahead and introduce Dr. Devlin. Michele, thank you for joining us today. As I mentioned, you are the Professor of Public Health and Education and Director of Iowa Center on Health Disparities at UNI. So obviously your background is quite pertinent, and I know you'll have great information to share with us as we examine health disparities in a new way with COVID. Would you like to go ahead and give us a brief overview of your area of research and how you introduce the subject of health inequities to your students?
Sure. Absolutely. Hi, good afternoon, everyone. Thank you so much for this really important discussion and a very timely discussion. So yes, my name is Michele Devlin. By background, I'm a doctor of public health, and I specialize actually in global public health and human migration and refugee care and mass disasters. So actually coronavirus and COVID and what's going on around the world is right up my alley, and for better or for worse, a perfect combination of my background and skills. I've been at UNI now for about 25 years as a global public health professor, but in addition to that, I do a tremendous amount of technical consulting and outreach and education, and have worked with and for numerous emergency response organizations and disaster organizations in the field of refugee health, minority, immigrant kinds of health, and other underserved populations. I do a lot of work and training with the military, the National Guard, police force, public health organizations, hospitals, city governments, nonprofits, and different folks like that in organizations. So it's been actually a very busy past few weeks and months as we look at this situation.
Yeah, I imagine with that background, both the global public health and your work with military and law enforcement, and I also read that on your bio that you are yourself an emergency medical technician. So that really gives you a unique perspective, I think, from many of us for both having the macro view of all this and the micro view.
Right.
How is that being able to look at it from both sides kind of playing out for you?
I have to say it's been really fascinating. I've been overwhelmed by it. So I did all my public health work at UCLA, where I'm from LA originally, but I've had my EMT license now for a number of years, originally in California and then here in Iowa as well. And then I'm actually shortly finishing up an evening program in nursing. So I'll have the nursing degree, also license anyway, in a couple more months. So it's been interesting to view this whole disease from the front end, the preventive and the big picture macro level. How can we keep populations safe? And I've been very involved with that, related again to culturally diverse populations, underserved groups, refugees and meatpacking plants, and that kind of thing, and prevention. But then I've been just overwhelmed at what's going on clinically, one-on-one. with the treatment of patients and their stories and the stories of the providers that are serving them, and how this disease in so many people, potentially up to 50, even 70% may not even show symptoms and they're asymptomatic, and yet others wind up getting ill and quite ill, and the illness can jump very, very quickly and become life-threatening for people and for a smaller percent of people. So I think actually having, being able to view it from the front end, preventive end, as well as the treatment end, keeps me up at night, but it does, I think, help me understand it in a much broader, much broader world.
Right. I think a lot of us are being kept up late at night for
Yes.
a lot of reasons these days.
Exactly. Yeah.
So, I mean, there's so many, COVID is so multifaceted, and there's purely the biological side of things, the infectious disease, the virality of it all. But then we know there's the social aspect, and about who is getting infected, who has the ability to work from home, as you and I are both doing now, shelter in place, and who doesn't. And what this does to infection rates, to spread, to consequences and severity of disease. There's social determinants of health that goes into all that. This week, IDPH did share data of COVID-19 cases by race for the first time. And I checked that this morning, and as we would expect, the majority of cases in Iowa are Caucasians. Today's numbers do show that when I looked this morning, 9.2% of the cases are individuals who identify as Black or African Americans, and 17.3% are Hispanic or Latino. So what does this tell you about Iowa's cases?
Unfortunately, it's exactly the kind of information that we were expecting would ultimately come out. I think if you work in the global public health arena and in the health disparities and health equity and inequities arena, we unfortunately expected to see this. There's nothing quite like infectious diseases that are highly transmissible to really affect special populations and subpopulations with a lot of challenges. And we expected to see this. I think initially a lot of the focus was on the elderly being affected, and frankly, especially older white populations. And that is correct. That is absolutely what we are seeing in the United States and in many other areas, and certainly in the West. But again, if you work in the global health field, you are also running sort of these simultaneous scenarios that this disease is going to explode, absolutely explode in high risk, lower income, culturally diverse populations that have other issues going on. And I can talk about those in a minute. So I remember even when this broke out 3 months ago, a lot of us in this field were talking to each other and trying to forewarn individuals, organizations, other groups, focus on the demographic that you think it's going to hit. Again, the older populations, older white populations, but you cannot do that solely, and you cannot do that at the expense of higher risk cultural populations. And sure enough, that's what we're seeing now in the data, even though those of us, again, that work in this field have known this is happening for a number of months. And thank you for sharing that information. I mean, yeah, we're looking basically at the, Hispanic rates of the cases, people that have the cases, it's 3 times higher, disproportionately than what the Hispanic population is in the state. And African Americans also 3 times higher than what their population is in the state. And what happens, what I think we're seeing nationally, and potentially in just the media and the lay public just talking about this issue, I think there's a lot of confusion between numbers versus rates, or in other words, percentages. And a lot of focus, rightly so, has been, give a lot of immediate attention, as it should be, in places like New York, where you have mass numbers of people being affected and dying every day, 600, 700, 800 or more a day type of thing, in California and New Jersey and other places. So we need to look at numbers, and those are large numbers, but we also have to look at percentages and at rates. And that's where you see the issue of underserved populations, special populations really just popping off the charts. You see it even in New York. Not only do they have the big numbers, but if you look at their lowest income, most culturally diverse boroughs, it's the 5 or so poorest, most diverse boroughs that are really, really exploding with death rates and infection rates and illness rates. Okay, and so we're seeing that too now, even in the Midwest, even in states like Iowa. These numbers and percentages that you share, the Hispanic and Black, not a surprise. We have a number of different populations that are very high risk in Iowa. And a lot of those numbers, a lot of that information you shared right now, fair amount of that, not all of it, but a fair amount of it is a reflection that we are a food processing state. That's one of our main occupational industries. That's one of the main things that we do. And so we have many communities that are food processing communities. Got meatpacking workers, poultry, pork, and others. The workforce of those plants is heavily diverse. You have a lot of local white Iowans and African-American Iowans and others, but you also have a tremendous number of immigrants and refugees that work within those plants as well. Some of those plants can have 20, 30 or more different languages spoken in them. And when you look at the linguistic diversity of Iowa, again, a lot of times, especially by outside media, we're perceived as sort of the white bread state and nothing is going on here in this part of the country compared to what you have on the coast. But we actually do have significant challenges here, and we're up to almost 200 different languages in the state right now, about 180 different languages. That's driven very heavily by the need for labor in a number of different industries, including food processing. So that's made up primarily of refugees and territory people and other H-1B visa folks and others that make up a growing number of workers in the state of Iowa.
Wow, I think I knew, of course, I'm familiar with the micropopulations and different linguistic groups and different immigrant populations, but I didn't realize that was over 200 or coming closer around 200. That's a lot. And I guess what's important, I'm glad you mentioned this, because the difference between rate and numbers, because I think those of us in public health, we, more intuitively understand that. But one of the things that I wonder is when people see those graphs and they see, it's like, well, 9.2% African Americans, but yet 72 or 73 are white. So the problem is larger in the white community. And we're not, like, as you said, it's not an issue in rural white older Iowans. It was certainly absolutely is, but it's the proportion and getting people and kind of explaining to people that when it's disproportionate to the number in the population, that's where the concern arises for these racial disparities and health inequities. And given the news in the recent days of the outbreaks in the meat processing plants, I think is the story of what you were saying with our labor force. Now, I don't have the data in my hands. Maybe you do, but many of the people that work in industries such as this may or may not have legal documentation for work status. You're talking about visas and immigration status. And what do you think, what are your thoughts on how that's driving case detection, follow-up, people's, whether or not they're able to stay home from work if they feel ill. I mean, that's the advice we've been getting from Governor Reynolds' office, which is sound advice. You're ill, you stay home. But when you don't feel that you have the option or it's safe for you to do so based upon your status, how do you feel that is driving rates and the conversation?
That is such a good question and a complex one. And we know from health issues in general that legal status definitely affects access to healthcare. It affects people's trust of the healthcare providers, law enforcement, and others. Are they willing to come forward and seek help? Are services being provided for them? Do they qualify for different services? Are there languages available for them? And all of this kind of thing. So that that certainly is an issue with a number of different diseases and illnesses and health issues around the country. It's been very interesting among the meatpacking and food processing industry, though. They have changed significantly in recent years. And I think a lot of us that have been in Iowa for a while remember the 2008 big post-bill immigration raid where 400 workers were arrested and the owners were arrested. And by the way, Aaron Rubashkin died recently of coronavirus at age 92. It's quite interesting, back in New York, I think. But before 2008, there was a larger percentage of workers that were not documented that were working in a lot of this industry. Frankly, since 2008, due to a lot of changes in immigration policy and labor and different kinds of things, we actually now see a much larger percentage of workers in the food processing industry that are legal. They are actually legal. So if they are on refugee status, or if they are on territory status, like you think of the Marshallese, the Palauans, the Pacific Islanders, we have a lot of them in the state of Iowa, they are all here legally. And that's actually why our level of diversity has exploded. Prior to 2008, we really had what was termed more rapid ethnic diversification. We had white population, African American. We had Hispanics growing in some Asian populations, but since 2008 and the big immigration raid and changes again in national policy about hiring and stricter enforcement of that, a lot of companies now recruit many workers from many different sources that are legal. And that's why now you can go into, let's say, a meatpacking town, and you easily could find employees and workers and neighbors from 10, 20, 30, 40, 50, 60 different nationalities. It's because they are recruiting from legal pockets. So we're getting refugees and migrants in from other states where they may work, and companies recruit them in from other states, and they become secondary migrants here and secondary refugees here. And so the workforce actually now is by and large legal, which makes this challenge even greater. These are not, by and large, undocumented workers that in the past have gotten, wrapped up into all of the rhetoric and legitimate issues that go on with what do you do with people that are undocumented in healthcare. So what do you do now when you've got 2,000 or 3,000 employees, very culturally diverse, including white Iowans, including African-American Iowans, in these plants and in these communities? And what do you do with them now when they're overwhelmingly legal? Okay, and they have the right to be here, and they're American citizens, many of them, or they're green card status. So what are you going to do with them? And that's why you're seeing some of the plants are actually shutting down around the United States very quickly. We've had several already in Iowa shut down. The Columbus Junction one shut down just, I think, last week, and then a few days ago, the one in Tama. We're seeing outbreaks all over the country in these types of industries where you have lots of people in very dense settings. If you've been in these plants, a lot of the food processing plants, they're fast and they're densely populated, and you've got people working on lines where you have to move the food along very quickly and cut it and package it and get it going. It's hard, frankly, to do social distancing. That's just something that just doesn't happen. It's difficult to make it happen in these kinds of plants. So we're seeing a significant chunk of people out sick and are trying to stay home. And you're correct, we do have the issue of housing. There are actually a number of reasons that as public health people, we should be aware of why these disparities are higher with some of our refugee immigrant and some of our minority populations in the state. One is that some of them actually have underlying health conditions. You're going to see other health disparities going on, things like diabetes, heart disease, lifestyle behaviors, smoking, activity levels, those kinds of things can be a bigger concern at younger ages in some of these populations. Some of these groups tend to be lower income, lower socioeconomic status, and we know public health and SES, go hand in hand. As they go down, they go down, go up, you go up. We're seeing health literacy challenges with a lot of populations, including white Iowans and Americans in general, let alone immigrants or migrants. But health literacy is information available in the language and in the way it needs to be provided to these populations for them to understand it. A lot of times, for a lot of us, the level it's provided is way too high, it's complicated, people aren't getting it, and it's difficult. Many of these populations too disproportionately work in the kinds of jobs where you are exposed to they're densely packed jobs. You're doing more hands-on things rather than white-collar office jobs. You're touching, you're close to each other. Infectious diseases of any kind, can spread much more quickly with this. And then we're also seeing that the problem is too, when they're told to go home and recover at home, or you're feeling sick, we can't test you, we don't have enough tests, but go home and self-isolate. That's one thing to say that to a higher income family that has a house, a nuclear family of 2 parents, 1 or 2 children, and they live in 2,300 square foot, of housing. What do you do if you're culturally, and if your family size is much larger? You may have a couple of parents, you may have the elders that are also being taken care of, another high-risk group of any race, right? And then you've got more than just 1 or 2 children, a number of children, and maybe brothers, sisters. So big extended families, right? High context families, call them in anthropology. So high context, communal-based families. They're more group-oriented. They see each other a lot. They go to each other's places. They spend most of their time with each other in large groups. And they also tend to live in housing that can be much smaller, much tighter. It's poor housing and it's more dense. So with this infectious disease, including most, density equals intensity in terms of the spread and the movement of the virus. And how are you going to self-isolate? So maybe you've got one person sick, they go back into very dense quarters. Where exactly are they going to self-isolate? They don't have any other housing available to live in or be in where they're alone. Okay, so you put them maybe in a bedroom alone in a little tiny apartment, but you've got another 5, 10, 6, whatever people in there, let alone people coming and going all the time. That it's the chance of getting infected and having this infection sort of be regurgitated again and again and again communally is a challenge. And so that's what we're seeing. And right now, one of the biggest, we have a number of problems especially with the, these kinds of workers, and they are not all refugees, they are not all immigrants. It also includes many Iowans and many white Iowans also, low-income populations. What are you going to do with them when they get sick? Can we test them all? Do we have the ability to shut down a plant for a few days, test every single one, and then isolate those, do contact tracing? Do we have isolation shelters when many of these people live in lower income or denser housing? So where are you going to put them all? Do we bring in the National Guard, which they do very well at this type of thing? Do you bring in the Guard and have the Guard set up temporary isolation shelter types of things in certain communities so that people can recover? They're sick, but they're together sick and they're not infecting other people that might not be sick. Or do we look at the use of all the hotel rooms that are in many communities now and are sitting empty? And can we do this type of thing very quickly, like in the next 2 days versus the next 2 to 3 weeks, to really try to stop the spread of this and these disparities?
No, I think those are excellent points, and I like your statement of density equals intensity. It makes sense, and I recognize that I am in one of those houses where we have more square foot than we have people, right. And just appreciating the luxury of that, but still the need to, or the desire to want to be part of the solution and not exacerbate the inequities that we have. As we talk about, many people are anxious to open things up, and we hear that from from our president. We hear that from more cautiously from our local leaders. And of course, we're going to have to, I hate to use the phrase return to normal, because in my mind, normal is part of the problem. It was what got us here. And so we're looking at a new normal that pushes us towards health equity. But I do fear that how long are people going to, people that have the ability to choose to social distance and comply with that request, how long are we going to stay tolerant of that before we start letting down our defenses, which then puts others that don't have that ability to social distance even at more risk. And so as we move into summer and as we move into fall, and again, people grow weary of this, and we know that as Americans, our attention span to anything is waning. But I do wonder, I think on the one hand, people will be nervous to return back to kind of a social life, if you want to say, but then on the other hand, we're also very eager and longing for that. So what health equity concerns do you have as we start to resume to daily life? I mean, there's the immediacy, and we know that we're going to be with coronavirus for a long time, but what that looks like in our community and that intensity and the spread is going to start to shift in these next few months. But it's still going to be present until we have a vaccine or herd immunity, both of which are a ways off. So again, what health equity concerns do you have as we start to open up and move it back around and such?
Yeah, it's a big challenge. On one end, some of these populations that we're talking about, in a certain way, they actually have the most immediate need to be working again. Sometimes they're being told from all kinds of companies. All kinds of companies are telling people to go home, self-isolate, just we're going to work from home or be at home. That's difficult. It's difficult for many Americans. It's especially difficult for people, and they're disproportionately represented by lower income populations, including low income whites, including rural whites that are underserved, and including a fair amount of minority and refugee immigrant kinds of populations, disproportionately represented in the kinds of jobs where they don't have the luxury of being able to work at home or just not working for a few months. I think today, just a few hours ago, both New York and California extended their stay at home orders until May 15th. So yet another month now. So again, it's hard, I think, on all of us. It's disproportionately hard on a lot of these special populations. And again, including white people that are lower income, lower SES, brackets. That's tough. How do you actually do it? And I think, I think jokingly, a lot of us have talked about how, maybe we're not keeping a 6-foot distance from the refrigerator while we're, watching Netflix for, 8 hours a day and this kind of thing. I think a lot of us feel like we're not getting the level of activity we used to or want to. Some of us are not eating the best way we probably should. There's boredom or just nervousness or stuff is going on. Stay-at-home orders are not without public health consequences, right? Unrelated to the spread of disease. We're certainly concerned in some communities about violence in some families, greater, domestic violence, abuse. We talk all the time about food stability, nutrition, are people food secure, this type of thing, if they're not kids, if they're not able to access meals at schools as easily as they used to be. So a lot of this stuff can disproportionately impact, again, lower income or diverse populations. And I use that term very broadly, not just racial or cultural diversity, economic diversity, okay, or any type of, rural versus urban, any type of special population. I think it's going to be a challenge. It's going to be a challenge.
Yeah. I think as we go forward and as we measure these different effects and collect the data, we're collecting data on cases and mortality right now, which are direct attributable to COVID-19. But as you mentioned, as we expand and as we move into the recovery phase, We also need to collect the data on those that attributable morbidity. You know, the excess deaths and diseases and consequences that maybe wouldn't have happened if we weren't in this pandemic. If we did have greater access or full access to medical services, if children were being seen in school by teachers and those mandated reporters that are as we heard yesterday, sadly not reporting cases of abuse. And so that attributable morbidity and mortality has to be measured, and has to be measured in a disaggregated way so that we can see how the disparities have played out. And so as we move towards that, and we look at kind of this in retrospect and lessons learned from all this, I guess, what advice do you have to policymakers, to local leaders, business leaders, to how do we do a comprehensive review of this so that we can not just be more prepared for the next large-scale public health threat, but really get to, as I said before, move towards equity in all of our policy and decision making, so that we don't these disparities and these inequities aren't as predictable in the future.
Yeah, great point. Unfortunately, I think sometimes around the world, around this country, and areas, we don't see enough forethought going into the needs of special populations, and particularly in emergency and disaster setting. The fallback is you serve the middle. As a disaster response, when you're short on resources, you don't know what else to do, you don't have a good feel for your community, you serve the middle and you just hope it sort of gets out there by osmosis, the resources, the information, and everything else. That's an old way of thinking, and it's a lethal way of operating, and it's a very dangerous way of operating. We have to have fundamental systemic reforms and infusions of resources and money and services to build up the systemic infrastructure of our country, of our state, of the world, and looking at the basics, back to Public Health 101, but it is so true. You cannot have good health. You can't have good public health without having good education, right? And without having jobs and economic development and having resources and all those other social determinants of health. They all play in to well-being. And part of what you're seeing in the United States right now with the huge the outbreaks and the disparities going on, again, for those of us that work in this field, and people have been asking, where did this come from? How did this happen? It's like, really? We've known this was going to be like this. We see it with every other condition. Why would it not be even more exacerbated with infectious diseases? I come out of the refugee health field and camps and kind of working in those types of disasters. One reason I got into that field as a student many years ago is because I wanted to help the worst of the worst, right? And usually in refugee camps, that's where we see disease rates that are literally 100 times worse than what they might be in a host community in a severe war zone, conflict zone. Well, those types of disparities, again, exist. They exist all over, and you've got to have policymakers and programming people and governments at local, county, state, national, international levels, provincial levels, working together to really make sure that everyone outside of that middle is also served. And we know how to do it. This isn't rocket science. We know how to do it. We know we infuse resources back into public health, the basics of health, the basics of education, the basics of literacy, the basics of economic power, and health status rises in a community, and it's more able to resist and be more resilient to these kinds of emergencies that we're seeing now. And the other thing I would mention too, and sort of when I talk to my students about this, sometimes you're hearing this thing about, well, this is a once in 100-year event. We used to say that too about floods, right? Oh, this is a once in a 500-year flood. for the third time in 5 years. Okay, all of this stuff is changing. We're in a whole new world. It's a brave new world now. And Corona, COVID-19, is simply one of numerous emerging infectious diseases that we have been seeing more and more of in just relatively recent years. I was very involved in the Ebola outbreak in Africa that we had just a few years ago. And, you know, and then we had West African refugees living in Iowa. They had people traveling back and forth. They themselves were nervous about family members coming to see them, you know, and this type of thing. So Ebola, Zika, dengue fever, chikungunya, all these diseases, we're seeing more and more of them. And I as bad as Corona is, it could be worse. It could be far worse with its case fatality rates, its percentages. It's bad enough it's highly transmissible. It could be worse. And this is just one of numerous emergent infectious diseases we're going to be dealing with as the globe itself becomes more overpopulated, more urbanized, as we have more and more literally globalization, transportation, movement, you know, interlinked supply chains that we're seeing, you know, all over the world, travel, climate change, climate, you know, human migration, and this type of stuff, and diversity. These situations are going to be happening more and more. If we don't try to address these issues, the inequities right now, the root causes of these inequities and disparities, we have a problem.
I agree, and I think not just in infectious diseases, but you know, antibiotic resistance is on the rise, and things, the kind of the complacency that maybe that's a harsh word, but that we had in being able to have a medicine, a solution for every problem, you know, at the urgent care clinic, is under threat, I would say now.
Yes.
And that security, I think, is as much unsettling to us, to many people, as the fear of the infection of COVID right now as well. I like to say, and I'm sure somebody said it, and I'm repeating them, but you know, when we're not intentional about addressing inequities, we risk unintentionally widening them. And I think that's kind of where we're at, is right now, this is where we're at. These disparities exist, these inequities exist. And so maybe right now, today, there's, you know, we are in crisis mode. We are in triage mode. But going forward, you know, how do we ensure that we are being intentional, and that these, the need to reduce disparities is understood as part of the critical solution and prevention going forward. And that's what I'm hoping we'll see, and that we can continue to raise voice to going forward as well.
Absolutely, Lina. And I think it's, and you kind of asked, like, you know, because I have both the public health perspective, my first love, and then some of the clinical stuff too. And I, you know, even today, most of the emphasis is looking at the clinical issues. You know, it's terrible, absolutely terrible what's happening to individual patients, individual nurses that are serving those patients, doctors, and everything. And that public health perspective is sometimes so big, because it should be, it has to be, but sometimes that's what makes it hard to understand, you know, by the public, what is going on and what are you actually doing, and what is public health? Isn't that a bunch of nurses that go out and do vaccines? Well, I mean, like, yeah, it's one part of it, but it's a lot bigger, and again, a lot of confusion over that. But you know, we're at the point where there's no free lunch anymore. You know, we are one world, and what happens in one location around the world, sooner or later, very likely will impact us, even in the middle of rural Iowa, even in the middle of farm communities, even in the middle of a meatpacking town. It affects us. I mean, you know, I think, you know, there's been enough talk about, you know, the growing urbanization and the reaching into places that used to be more wild, right? And I do a lot of work in human trafficking and labor trafficking as well. And actually, illegal wildlife trading is also, I've been involved in some of that, and trafficking of wildlife. You know, part of that is connected as well, because some of these coronaviruses, or, you know, SARS and different things, there's been a link to illegal wildlife trafficking and the movement of dense human populations into, and Ebola, into areas that we didn't used to be so heavily involved in. Again, and all of this stuff comes back ultimately all around the world.
Absolutely. Well, we've gotten a couple questions that are coming in from the chat, and I encourage anybody at this point too, where we have about 20 minutes left on this session. Feel free to open to ask your questions in the chat, and I'll kind of help pitch those to Michele. But one of the ones we have here is, how can we support, and I think this is an important one, how can we support the reestablishment of the federal pandemic preparedness team?
Yes, I know this one has been incredibly frustrating, I think, to all of us in public health, all of us in global health, and especially to those of us that do disasters. I mean, we are the chaos management people. If you're in the disaster element of public health response, you cannot operate anywhere in the world at this point without having those types of offices, those types of entities at the federal, at the national level, and then even at the global level. You know, and a lot of times at the lower level, the county level, you know, or the village or town level, depending on where you are in the world, you've got local governments that help. But very often what we're seeing globally is an increase in mega disasters. And this is a mega disaster, right? It's a pandemic mega disaster. Those types of disasters overwhelm resources at the local level. They usually overwhelm them in the US at the county level and even at the state level. You must have federal response. You must have national response in any country to deal with these types of situations, because you've got to be able to operating things at sort of a macro level and the backup, you know, to take care of things at many of those local levels, and I would argue at the international level as well. It's not an option anymore.
I've heard from colleagues in local public health and others that, and that the funding, you know, of course, our programmatic priorities follow the funding streams, right? That's typical in public health and grant funding, and whatever the kind of the topic du jour is where all the big funders, whether that's federal funding or the Robert Wood Johnsons and the Gates Foundations and kind of their priorities. And, you know, years ago, we had a big boon in funding for preparedness, and then priorities shift, and, you know, plans were made and things were put in place and people were trained. But then as funding streams shift, so do people's positions shift. And so we've had in some areas kind of a loss of institutional memory from some of the preparedness exercises that we did a decade ago. Right. And so the need to maintain, kind of like kids do, you know, every year they do their tornado drill in school, kind of our preparedness planning, and having that as a kind of a constant in our workplaces and our planning programs and our long-term and our fiscal management and such seems to be more essential than ever.
Yes, it's painful. It's painful to see this. And again, the global trends is that we're going to get more and more disasters, larger disasters, mega disasters, you know, continental disasters, international and global disasters like this. We need more of these types of resources and services and organizations, not fewer. We can live in denial. It's actually getting worse at this point. Again, because of the big global trends that I talked about, the globalization, increasing urbanization, dense urbanization, you know, reaching into wilderness areas that did, you know, used to be so heavily populated, climate change, human migration, growing economic disparities around the world, and these types of things. So, you know, the one in 100 years mega pandemic,
not anymore.
You know, think of the flooding. Yeah.
Yeah, there's been a couple questions that have popped up about kind of back to the workforce and especially the large meat processing and packaging industries, and kind of, are you aware of what's happening in those industries to support those workers in terms of health insurance, in terms of health literacy, in terms of access to care, and again, worker protection, that is so important independent of COVID, but especially now?
Yeah, absolutely. And I'm seeing some of these questions too, and thank you for asking them, folks, that I turned them in. They're great questions. So it's interesting with the meatpacking and food processing industries. They are, like most industries, not perfect, but they have come a long way. I have to say they've actually gotten better. They've come a long way. I've been looking at dealing with refugee health issues and meatpacking refugee health issues for about 20 years now in Iowa. It's a different place in the US in Iowa than it was 20 years ago. When I first got here, a fair amount of the immigrants were undocumented. They were, and so they were scared to seek care. There was a lot of underground stuff going on, issues of health insurance that was rare, benefits, things like that. Again, really since 2008, there are different models now operating in the US and with a lot of these companies, and they are, to the best of their ability, by and large, trying to hire people that are here legally. And that's why, since we have a labor shortage in Iowa in terms of local Americans that are willing, and enough of them willing to do that kind of work, we just don't have enough people, period. They do rely on a lot of refugee workers and territory tree workers. The salaries for these jobs have gone up. Right, they've gone up. A lot of them now are paying $18, $20 an hour in a number of these plants. It's a lot higher than it used to be. Some of them initially were not providing health insurance. Now a lot of them do. So this has gotten better. There are still issues and confusion, especially if you're, say, a refugee in different languages. What's a deductible? What's a co-payment? Can I still afford that even if I do have health insurance and this kind of thing? But they do have occupational health nurses in these facilities that do their best to also be on the front lines and help people. So it's gotten better. A lot of the you're right. The health, I see health literacy issues here in questions. That's always been a challenge. It's a challenge right now, again, in the U.S. and in the state of Iowa with 180 different languages, and from a public health standpoint, it's hard to get messaging across, especially if you've got a big chunk of those languages are technically classified as rare languages. You cannot find an interpreter. They are literally rare in the language. So that's an issue. And a lot of the education is best provided face-to-face, but you need written supplements. Well, if you've got populations that are not literate, even in their native language, let alone in English, this becomes more difficult. So that's an area of concern. It'll be interesting to see how this plays out. You're right. I mean, these are for-profit companies. They have a vested interest in having healthy, effective, an effective workforce that's healthy. So many of them have actually been involved with governors and states and trying to figure out ways to deal with the spread and serve their employees and the host communities as well.
We have a couple of questions that have come in that I think kind of go hand in hand. The first one is, what's the most important thing we need to do right now to further reduce inequities? And then the next question is talking about public health funding. And so I think, again, that gets back to the micro and the macro level of things. So I'm wondering if you want to respond to that from your point of view. Kind of
Sure.
what are some of the things that we can do as individuals, and what do we need to do collectively?
Sure. So I think right now as public health workers, and I think a lot of us are in public health departments or universities or schools or nonprofits or whatever, we're on the front lines. It's getting the message across to the programmers, the policymakers, that we are not a state that should be ignored in terms of this type of infection and virus, nor should the Midwest in general. These rural states were often being ignored, and it's viewed that, well, it's a bunch of white people and they're not going to have many issues and it's going to be just fine. We need to immediately look at our special populations, and it does include white people. Rural whites, rural older whites are very high risk. And look in your communities. If you are a food processing plant kind of community, and we have a lot of them, Waterloo, Postville, Denison, Columbus Junction, Perry, Storm Lake, you know who you are, Marshalltown. If you're those kinds of communities, we have high risk situations going on right now because of, for all those reasons that I talked about. And you need to get ahead of that challenge, not wait until it becomes such an issue. We know that these inequities are there. If you have African American populations, again, or Hispanic populations, I don't care where they work, we know that disparities are bigger among those groups for many different health issues. We know that particularly for infectious diseases like COVID, can spread like wildfire. Again, they should be part of the planning process. You should be meeting with key leaders in those communities, faith leaders, to help get messaging out, to help be part of the emergency operations centers in these different communities. We're lucky here in Waterloo, we've got a number of groups like Embark that do a lot of work with the rare language people. You know, the people from Burma, for instance, speaking locally, maybe 7 different languages. Okay, well, who's going to handle that and run with that in an emergency? So look to your local nonprofits, your ethnic associations, your for-profit employers absolutely should be part of emergency operations and planning. So that I
think that's such a good yeah, such a good reminder that when we look ahead to planning, that that more than doing for, we need to do with, and bringing
Correct.
people to the table to be part of the conversations from the beginning, for the planning, for planning for prevention, planning for response, planning for recovery. Like I said before, as we go forward and we start to look at the knock-on effects of COVID and how we are recovering as an economy, and how we are recovering as communities, we need to continue to look at those, disaggregate the data, look at who is recovering and who's still not recovering. I mean, the same thing that we saw after hurricanes and after other natural disasters and such, because we again know that the same issues that cause higher complications for some people with the disease itself will also be those conditions that slow down the recovery in those communities as well. And so we can't emphasize enough the importance of bringing people together and having voices and having inclusion when we have conversations at the local level, when we have conversations with our state legislators, when we advocate at the federal level.
Yeah, absolutely. Well, it brings up a good point, Lina. You're right, and especially in the emergency sector, disaster response, emergency planning, that's a constant planning cycle. And a lot of times, again, unfortunately, we can get complacent. We'll deal with it when the flood hits, when the pandemic hits, when the hurricane hits, the typhoon, whatever it may be. That type of planning and preparation and mitigation and the resiliency, it needs to be going on every single day, every single year with the organizations and with the communities impacted. That would be the potential, people that would be affected by these types of conditions. And again, I agree with you. I'm a firm believer in not doing things for, but trying to do those interventions and planning and resiliency and development of the infrastructure, doing that with the communities affected. They have the best on the ground knowledge of their own people, their own needs, their own barriers and strengths and opportunities that they can bring to the table. So they are critical partners to have involved, again, in all of all these different ways, not just racial and cultural minorities, but again, our low-income whites, our rural populations, our farm populations, and any group that would be considered underserved or at risk. We have many of them here in this.
We have another question that's come in, and yet another unique population that needs to be considered. The question is about public health departments working with Department of Corrections and making sure that we are being intentional about how we do case detection and monitoring and relief and recovery with the Department of Corrections. And as people transition from the correction system back into communities and such, and making sure that there's equity considerations in those decisions as well.
Absolutely. And if you look at the racial disparities and mental health, and the percent of people that have mental comorbidity of mental health issues that get worked into the legal system and all of that, and low-income people, again, of any race or ethnicity. And again, the racial and ethnic disparities in that, those are going to be high-risk populations for this, as well as any other type of health issue that we're looking at. You just know that those are going to be groups of people that you need to really work with the DOC and the incarcerated populations. Here, for instance, within Waterloo, I do know they're looking at that very heavily. Our Emergency Operations Center is actually directed by Tony Thompson, who's our sheriff, and has made a very active effort at trying to get the corrections people involved and really intimately knowing those situations and what's going on. So yeah, I would definitely include them as a high risk environment.
Yeah, great. Well, this hour has just flown by, and I know this is such an important conversation that we could continue on for quite some time, and I'm sure conversations will continue on after we log off here, and I encourage people to do that. So I just want to thank you for spending your time with us today and sharing your work and your expertise with us. And again, we can't say enough that how important it is to be intentional about addressing health disparities so that we don't, like I said before, inadvertently widen them. And conversations like this are important for that. Sometimes I feel like we are preaching to the choir a bit, but I think that it's always good to be reminded and of that, the need for intentionality. So thank you again for spending your time with us. Thank you to everybody who's online, who shared your lunch hour with us. We hope that you will join us again next month and bring a friend. We do this third Thursday Lunch and Learn series every month. So next month, May 21st, Jamie Haberl of the Healthy Estate Initiative will be with us. And she'll be talking about mental health needs and resources, which it's, again, I mean, talk about a timely subject and one that is full of health inequities and need to address it from a systems level. So thank you again, everybody, for joining us. The IPHA Education Committee is still planning these. We'll continue to plan these throughout the year, and we welcome your ideas for future Lunch and Learns and encourage anyone with an interest to send us a note or even join us at IPHA and join the committee for planning. As a nonprofit organization, IPHA does rely on membership dues and sustaining donors to support our mission. If you're not already a member, please consider joining IPHA. Students, feel free to check with your department chairs, as many programs do have funds to support student memberships. If you are a member, thank you for being a member. We appreciate your sharing your time and your talents with us. And also appreciate any donations that fits within people's budgets. We are a nonprofit 501c3 organization. This recording of this Lunch and Learn and all of our Lunch and Learns will be archived at Iowa Public Health Association's YouTube channel. You can find it there. And you can find other webinars that you may have missed in the past, including our virtual Iowa Governor's Conference on Public Health sessions. This is not one of those sessions, but we will be back to the virtual Governor's Conference tomorrow. So thank you again, everyone, and we will see you next month.
Thanks, everybody. Thank you.
Thank you.